Easy to create intrastomal lenticule with one corneal incision. The VisuMax is the platform for the current SMILE procedure. More than 2 million SMILE procedures have been performed worldwide. The VisuMax was approved by the FDA in 2016 for the treatment of myopia, and in 2018 it was approved for the treatment of myopic astigmatism. The current approved treatment is for myopia up to -10 diopters, with astigmatism up to -3, with a total spherical equivalent of no more than 10 diopters. This is a schematic view of the SMILE incisions with the cap and lenticule already cut, and the parameters can be modified on the machine. However, there are some technical issues with the SMILE. The VisuMax does not have cyclotorsion compensation, which can occur for various reasons. It usually occurs naturally from sitting to supine position, positioning of the head and turning the face, the speculum and patient's resistance to it and Bell's phenomena, the applanation and suction can induce cyclotorsion. There are also some problems with centration accuracy. In LASIK and PRK, there is usually clinically relevant higher order aberrations being induced due to decentration. The VisuMax does not have a pupil centration and tracking. Usually the centration is along the patient's line of sight and may be away from the pupil center if the patient has a large angle kappa. And asking the patient to look at the microscope light gives an idea about the angle kappa. What about the SMILE claims that it reduces the iatrogenic dry eye with better recovery of corneal sensations and a biomechanically stronger cornea? So the SMILE advantages over LASIK, is it a fact or a fiction? Dry eye disease is the most common complication and a frequent cause of patient dissatisfaction after corneal refractive surgery, either LASIK, SMILE, or PRK. In LASIK, the subbasal nerve bundles and superficial stromal bundles in the flap interface are cut by the microkeratome or the femtosecond laser, with only the nerves entering the flap through the hinge region being spared. Subsequently, the excimer laser ablation severs further stromal nerve bundles. Therefore, corneal sensation is decreased while the nerves regenerate. Following the introduction of SMILE, there was an expectation that SMILE may demonstrate an improvement in the postoperative dry eye compared to LASIK, given that the anterior cornea is left untouched other than the small incision. As shown here, there is a schematic view of the subbasal nerve plexus. In the femtosecond laser, as we see that these nerves are transected along the 300 or 300 degrees arc length. However, in the SMILE, it is usually transected in a small area. And on the right side, we can see the confocal microscopy, preoperative and 1 year postoperative patients of the PRK, LASIK versus the SMILE. What about the studies? Most studies found that dry eye worsened after either laser refractive procedures. However, there was a general trend favoring SMILE in inducing less iatrogenic dry eye compared to femtolasic when comparing outcome of the studies. And the recovery of tear backup time in SMILE patient was observed at 3 months. In comparison, the femtosecond LASIK patients had a recovery of tear backup time at 6 months. This is an example of some of the studies. In Blametel's study, 10-year review of the SMILE, he concluded that no patients needed further dry eye treatment after 3 months. Other study found that the mean tear backup time returned to preoperative levels at 3 months in SMILE compared to 6 months in femtolasic. And Chen et al. In meta-analysis found a significantly higher tear backup time scores in SMILE compared to femtolasic, except for 1 week after surgery. A more recent meta-analysis found also that a significant reduction in the post-operative tear production as well as tear backup time was seen with LASIK, with a non-significant reduction was seen with SMILE. Corneal sensation. Most studies reported reduced corneal sensitivity in the femtosecond LASIK group compared to SMILE. Kai et al. In 2017 found that SMILE had better corneal sensations at 1 week and 3 months, while at 6 months there was no difference. Chen et al. Found that the corneal sensitivity in the SMILE group was higher than the femtosecond LASIK at 6 months post-operative. Regarding the biomechanical stability, SMILE has been theorized to have some biomechanical benefits in normal corneas when compared to LASIK, and this advantage is thought to be directly related to the preservation of the anterior-most corneal stromal fibers, which are known to impart the greatest tensile strength in the normal corneas. However, in reviewing the literature, there were inconsistent reports in the literature regarding the corneal biomechanical stability in SMILE versus LASIK. Like Cao et al. In 2019 found that after lenticular creation, the deformation amplitude ratio was bigger and the central corneal thickness was thicker compared in the SMILE compared to flap creation, suggesting weaker mechanics in the SMILE. However, another study in Hamar et al. In 2019 found that creating the LASIK flap caused a greater biomechanical change in the cornea than the SMILE cap. In a recent study, which I find very important, about the incidence of ectasia after SMILE from high volume refractive surgery center in India, which was published in the Journal of Refractive Surgery in 2021, they recruited about 7,000 eyes were analyzed and almost 6,000 eyes underwent SMILE. 10 of these eyes developed ectasia at a mean follow-up of 21 months. In this study, they classified the eyes as normal or borderline depending on different criteria, including the CBI and TBI and additional risk factors for young age and family history of keratoconus or eye rubbing. If none of the above criteria were present, eyes were classified as normal. However, if 3 or more criteria were present, eyes were classified as borderline. And all the eyes in the normal group underwent SMILE. However, in the borderline group, eyes underwent SMILE extra, and some underwent SMILE based on the surgeon's intuition, the cost of the end of the procedure. As we found that 10 eyes developed ectasia. In the normal eyes that underwent SMILE, 2 eyes developed ectasia. However, in the borderline eyes that underwent SMILE, 8 eyes developed ectasia, and 0 eyes developed ectasia in the SMILE extra group. It was found that the incidence of ectasia was higher in borderline eyes undergoing SMILE, 1.3% versus the normal eyes, reiterating the importance of careful treatment planning similar to LASIK. And most of these ectasia eyes were the outcome of improper treatment planning, resulting from the assumption that SMILE may be biomechanically superior when compared to LASIK. Randleman, in his editorial Ectasia After SMILE Revisited, found that theory has now been tested and found to be incorrect. And borderline cases had surgery and developed ectasia at an unacceptably high rate, and the primary message to avoid SMILE in borderline eyes is clear. So to review, at the present time, femtosecond LASIK remains the most commonly performed laser refractive surgery. SMILE is still emerging as a relatively new laser refractive treatment since its FDA approval in 2016. It has challenges, drawbacks. There's a steep learning curve initially, many potential complications related to lenticular dissection and removal, which may occur lead to inferior visual outcomes. Other drawbacks are limitation with enhancement and lack of formally established method for retreatment of post-operative refractive errors. So to conclude, SMILE includes no flap-related complication. However, it lacks sight rotation compensation, eye tracking system, and customized treatment profile. SMILE induces less iatrogenic dry eye. It has limited or any role in eyes that are deemed to be at high risk for post-operative ectasia and therefore excluded from LASIK due to biomechanical concerns. So the patient that is not candidate for LASIK is not a candidate for SMILE. SMILE may be a good option for patients who play contact sports in order to avoid flap-related complications, and in patients who suffer from moderate dry eye disease pre-operatively. And thank you for your attention.